各位委員，啱啱好。
Right, members, we just made the quorum with you in here. Item number 1, confirmation of minutes. The minutes of the meeting held on December 17th have been made available to members who have received no proposed amendments. Unless I hear any problems, can I take the minutes as confirmed? Thank you. Item 2, information papers issued since the last meeting. There is no paper in this agenda item. Items for discussion at the next meeting shall invite the administration in to join us, please. The list of outstanding items and the list of follow-up actions have been made available to members. Ms. Claudia MO wrote in to suggest that we discuss the import and sale of Chinese medicinal products containing ingredients from bear gall bladders in Hong Kong. We discussed this on May the 14th after receiving Ms. Mo's letter. We have invited the administration to make a response, which has also been made available to members. Under Secretary, Ka-lau. Date of the next meeting, March the 18th. The administration proposes 3 things: development of Chinese medicine, reprovisioning of Yau Ma Tei Specialist Clinic at Queen Elizabeth Hospital, and also electronic health record sharing. The Chinese medicine item was supposed to be taken today, but this has been put off by the administration because the newly created TCM committee has not got underway until next month. So that's why this item has been shifted to next month. Any comments on those 3 items? Mr. Chen Hanpan. Chairman, I've got a suggestion to make. I'd like to bring up this issue of A&E department. I'm going to write in with my submission. We have heard a lot of reports over the Chinese New Year. According to Oriental Daily, over the first 4 days of the Lunar New Year, there has been an upsurge in attendances. The administration told us that more resources will be devoted, with more manpower to be recruited. I hope that at the meeting on March 18th, we will be brought up to date about the manpower situation, the recruitment, and so on. There's going to be a holiday coming up, the Easter holiday. Again, it is going to be a critical period as far as A&E departments are concerned. Comments? All right, there are 3 items on the agenda. There are 2 ways to go about it. One is to cover 4 items, which means that we're going to have an extended meeting. Instead of 4:30 to 6:30, we may need to have another hour. Or alternatively, if some of the items can be put off for another month, we can certainly do so. Your comments, please. No comments. I would be inclined to have an extended meeting to cover as much as we can. Under Secretary. All right, then we have one additional item on A&E. Perhaps we can have an extension by 1 hour. Well, we certainly would go over the time with 3 items there. In particular, we'll have the TCM item. So March the 18th, we're going to have the meeting between 4:30 and 7:30. Development of Chinese medicine reprovision of Yamate, Specialist Clinic at QEH, Electronic Health Record, and A&E departments. Mr. Joseph Lee. Well, the electronic health record sharing, is it an update? What was there to talk about? I don't mind having long meetings, but if this is not an urgent item, if members feel that A&E departments are more urgent, she will have a special meeting. We should have a look at the items proposed by the administration. The TCM, they suggested that we shift it to another meeting. I mean, if we don't have enough items, we can leave here by 5:30. But if there is an item which is of an urgent nature, perhaps the administration might wish to leave some of the items which are not urgent off the agenda. Right, electronic health record sharing, what's it all about? Under Secretary. Chairman, it is going to be an update. I certainly can have a look to see whether we should take this at the next meeting. We don't have to make a decision today. Like the TCM, it was subsequently that we were informed of the shift. It is all about a funding proposal. All right, and let the Undersecretary have a look at the health, electronic health record sharing. If it is of an urgent nature, then we will cover 4 items in the 3 hours. Otherwise, we will drop that item off the agenda. Mr. Lee. Well, I'm sure that the administration should be aware of what items are of an urgent nature, like some of the preview items that may be more urgent. She said that she has to go back and have a look at it. We're not sure how long the meeting is going to be lasting for, 2 hours, 3 hours, or what. Can you help, Under Secretary? The electronic health records sharing. Well, the relevant colleagues are not here. It is about an update. So with your indulgence, Chairman, I'd like to double check on this one. But she's not familiar with the subject. There is nothing much we can do about it.
All
right, I'm not sure whether you've read the administration's reply to Ms. Claudia MO's letter. Any comments there? Basically, Ms. Claudia MO would like to follow up on the control over proprietary Chinese medicines containing bear gall bladders. The administration said in reply that these products will have to be in compliance with the exporting jurisdiction's regulations, if I understand the letter correctly. Now, if that's the case, there is nothing much that we have to follow up on. All right, then let's move on to the next item, the ward renovation of Kwai Chung Hospital. All members have been invited to attend the meeting for these items. Rules of Procedure 83A about declaration of interest. Members are not supposed to move any motion or amendments on subjects with pecuniary interest or speak on the subject unless there is a declaration or disclosure of those interests. So just a reminder that if there is any direct or indirect pecuniary interest, please make the disclosure before you take the floor to speak. I'd like to invite Professor Chan to take us through the paper, please. Chairman, thank you. This is about the renovation of the Kwai Chung Hospital. This is a psychiatric hospital in Kowloon West Cluster, covering Kwai Chung, Tsuen Wan, North Lantau, Mong Kok, Siam Shui Po, and Wong Tai Sin districts. It is providing the psychiatric care services that include assessment, hospitalization, and so on. 1981, when the hospital was commissioned, the occupancy rate or utilization rate has been pretty high, and that has contributed to the wear and tear of the hospital. So since its inception, the hospital was underwent some routine maintenance and repair, but we haven't had any massive renovation projects. The situation is it is in a dilapidated state, and some of the facilities are suffering from malfunctioning, and the situation is getting rather serious. And this is an undesirable situation. And this is indeed getting in the way of the operation of the wards and carry some risks of infection control. There is an urgent need for us to get on with the renovation to make sure that the hospital will be providing the services effectively with a view to maintaining the safety of the staff and the patients. The proposed renovation project covers the repairs to spalling concrete, the floor and ceiling tiles, the plumbing and drainage pipes will be replaced. Building services and facilities will also be replaced. The entire project will cost us $48 million with subject to members' support. We will be seeking funding from the Finance Committee in July this year. And subject to Finance Committee's approval, the renovation work of the walls will get underway straight away. It is expected that by the end of 2014, all the works would have been completed. And I'd like to urge members to support this renovation project. Thank you.
Mr. Lee Portland, KK Kwok, Chen Hanpeng, and Mr. Poon and Mr. Hong Kong waiting to speak, and Madam Mack. Alice Mack, 4 minutes each. Mr. Lee. Thank you, Chairman. I welcome the proposal. I have to declare my interest. I'm on the board, and I support the renovation proposal. I hope you can get the funding so the work can start in July. And you expect work to be completed in October this year. You're asking for $48 million. Is it sufficient? Are you going to ask for more? Infrastructural renovation is something important. I hope you will get the funding you need. Next question about the beds. Well, you're not going to do anything about the beds. You're going to do some renovation to the interior of the buildings, right? Now, there will be a redevelopment project of KCH. How many beds are you going to have under the redevelopment? You are spreading the patients in different places, and some of them do not stay in the hospital. So how many beds are you going to have, and the sizes of the beds, what are they like? Because these will have implications on the patients. Thank you, Mr. Lee, for the questions. First of all, in our estimates, the works will start in July if everything goes swimmingly. And for the $48 million, according to our calculation, that should be enough. As for the details of the works, Mr. Lee can supplement on that. Concerning the redevelopment, Mr. Lee, you are right in saying that the renovation will cover mainly the walls, etc. And so there will not be any implication on the beds. Now we consider that for the other areas that can be taken into account in the redevelopment. So when we come back to you to talk about the redevelopment, we'll have more comprehensive plans, especially about the changes in number of beds. Concerning the redevelopment, as Mr. Lee has pointed out, we will focus on helping the psychiatric patients, mental patients, to return to community, to be integrated in the community. That's why I do not expect a high increase in the number of beds. As for the details, that will be announced to members later. Any supplement? Mr. Lee, whether $48 million enough, this is the estimate, in fact, and with your support, we will go forward with the tendering. After that, we will know the exact amount we need, and that will be the benchmark of the funding we're asking for. Thank you. Dr. Chang, is it the case that you have something to add? Right. Concerning the service, for the future redevelopment and the renovation we're proposing, all these are for the provision of services. In the coming 20 years, we'll increase dozens of beds with the hope that we can accommodate future needs. Apart from that, in the community, we will throw in more resources as well. For example, we will enhance the manager-based service. We'll expand it to 18 districts to give support to adolescent elderly people who suffer from mental illness. Mr. K.K. Kwok. Well, of course, we have to support the ward renovation. In fact, 2 weeks ago, before the Chinese New Year, some organizations related to mental illness came to the LegCo to put forward their views. Most of them were suffering from mental illness, and some of them are family members of these people. And of course, we like to see such renovation projects. Now, these people have told us the hygiene condition is not very well in certain hospitals. I dare not repeat all these again. This is just horrifying. Now, even if you get the funding of $48 million, you will have to wait till next year for the project to be completed, and the redevelopment will only start in 2015, and it will be completed in 2023. That means people have to suffer for more than 10 years. Do you have any concrete plans to improve the situation? The paper is simply too brief. You mentioned the toilet situation, the space, or the size of the beds, but I don't think all these are suitable for the patients, for humans. So I would like to get more details. How come the patients have to wait 10 more years for better situation? Don't make them wait for so long. This is really something we cannot accept. Thank you, Mr. Kwok. Concerning the time frame, 2023, that's what we're looking at. But we hope we can get the renovation underway as soon as possible, because this will relieve the situation somewhat. And you are right in pointing out that some areas are really appalling. Dr. Low is here, who is from the hospital authority, perhaps, who is from KCH. Perhaps he can tell you more about the details. For the ward renovation, we will cover 9 inpatient wards, and we'll also renovate certain public areas. After the wards have been renovated, patients will move in The works cover certain areas of concern. For example, the water leakage in toilets, private space of patients. We hope we can also improve on that, to improve on the areas for them to place their personal belongings. For example, this is a chance for us to do that, to enhance on the hardware. Now, if we go ahead with the redevelopment, we can better address all these problems. Undersecretary mentioned the structure or the situation of KCH, especially we have the problem of spoiling concrete. And in the renovation, we will have an overall review of the structural safety of the hospital. So the renovation covers the 3 areas I've just mentioned. Now, for the toilets, people have to squat down to use the toilets, so it's not convenient for the elderly patients. Another question is also about renovation. You know, sometimes even if the family members do not want the patients to be discharged, they are discharged. So how can you address this? Dr. Low? Thank you for the 2 questions. Concerning the squatting type toilet, we have a certain number of such toilets in the ward because some patients do need to use such toilets. But for most of the toilets, they are the sitting type. Discharge of patients is not related to the renovation project. It is dependent on the clinical situation, clinical condition. It's only when we're satisfied with their condition that they will be discharged. So it's not because of a renovation project that people will be asked to be discharged earlier. What about the beds? In the redevelopment and renovation projects, we will keep the same number of beds, that is 920. Mr. Chen Hangpan. We support the renovation proposal of KCH because you will improve on the environment for the patients and the family members. This is beneficial to them. I hope you can roll out the project as soon as possible. You mentioned the hospital will remain functional at all times. I would like to know if there will be certain services which will be affected during the renovation, and what sort of impacts are we looking at, if any? And if there are implications, what sort of plans do you have to minimize the problems? Or can I say there will not be any implications or impact? Also, how can you minimize the impact, if any? Thank you. As far as I understand, the renovation will be carried out in phases. We'll conduct renovation for 2 wards every 3 months. As for the implication and how we can minimize implication, I'll defer to Dr. Low. Dr. Low, please. Thank you. We would like to minimize the impact. For the proposal, clinical services stand to be affected will be the daycare services. We will reserve room or space for operational purposes during the renovation. So the quality and quantity of the clinical service will not be changed. In other words, if we have to renovate a certain place, the services will be relocated to another area. That's why we do not expect much impact. Of course, the inconvenience will be caused during the renovation. So we will have plans for the patients and family members and members of the public when they come to KCH. Now, the hospital is 32 years old. It's rather old. And in the past, people used asbestos. Now, in that case, I would like to know whether this material is used, and if so, what sort of plans do you have to address this in terms of safety? Mr. Lee, we haven't detected any asbestos in KCH. Next, Mr. Poon. Just now, Mr. K.K. Kwok mentioned that just before the Chinese New Year, we heard the opinions of mental patients who pointed out that there are plumbing problems and water leakage in the toilets. That's why it's a pressing issue, this renovation project. You will start the works in July this year, and the works will be completed in 2014. And the redevelopment will start in mid-2015. In other words, 6 months after the renovation, you will start the redevelopment. You're going to renovate certain blocks, say, for example, GH. Do you mean you will demolish the blocks? If that's the case, we're talking about a really short timetable. And you said the functions will not be affected. But you will renovate the wards, not just the public areas. So does it mean that 6 months after the renovation, you will start the redevelopment?
The Secretary, thanks very much, Mr. Poon. My understanding is that for blocks M and J, M and L, they will not be worked on until the very last stage, because they are the newest of them all. Dr. Low? Well, Chairman, most of the renovation projects that will be focused in blocks L and M, they will be left till the very last stage in the redevelopment project, and they will be in use for another 7 to 8 years. And blocks G and H, as I said a moment ago, they will provide space for the services to be provided. So we like to focus our renovation resources on the blocks that will be redeveloped at a very, very late stage. Mr. Vincent Fang, Chairman, Declaration of Interest. I am Chairman of the Governing Committee of Princess Margaret Hospital and Kwai Chung Hospital. Before the Lunar New Year, we met some people concerned about the mental health, and they are picking the Kwai Chung Hospital to pieces. We've heard nothing positive about this particular hospital. I think the blame should rest with the administration. Why is it that you are still seeking $48 million for a hospital which is in such a dilapidated state? The concrete is almost falling. Now these $48 million will be used for renovation, and in a couple of years' time you're going to be pulling it all down. Now the situation is so undesirable. It is in a horrendous state. According to the patients are more or less like inmates. And I feel really upset hearing this. The situation is so bad over the years, I've been urging the administration to redevelop Kwai Chung Hospital, and 8 or 9 years on, and they are presenting a proposal to us. And for G&H, you will be renovating them. You said that this is difficult. I think it would be even more difficult when you redevelop the hospital, because you have to set aside certain space. If you look at the drawing, the only space available for you would be the car park area. Will you be building a block at the car park and then shift everything over there? Now, this will cost us $48 million for the renovation, and you try to extend the utilization period of the newer blocks. Now, I think that certainly there would be some impacts on the patients. It would take 8 to 9 years for the redevelopment to be completed, and the whole Kwai Chung Hospital will be in a shambles. It would be difficult enough to renovate the wards. It would not be hard to imagine how bad it's going to be for redevelopment. Now, you said that you try to maintain the services. I think you can try your best, but I would be surprised to hear. I wouldn't be surprised to hear complaints of flooding in over the next 8 to 9 years. I think you have to be prepare yourself for that. Undersecretary? Perhaps I defer to Dr. Low, who will be responding to Mr. Fang regarding the utilization of the car park area. Dr. Low. Thanks very much, Mr. Fang. Basically, we have been discussing the redevelopment of Kwai Chung Hospital for many years. We'd like to see this completed as soon as possible. Our preliminary view is that this renovation project is feasible, because when we carry this out in phases, we can create space to make sure that the clinical services can be provided in the new space to be made available. We will keep the blocks for the inpatients to receive the treatment. Certainly, we will have to re-provision the wards. Now, we don't have we don't really want to re-provision the wards more than once. During the renovation, the wards will be moved out, and by the time the projects are completed, they will be moved back. There will not be any situation of a double decanting exercises to keep the impact to the minimum. Of course, the patients, the family members and members of the public will suffer from some impacts as far as public space is concerned during the period of renovation. We will try to increase the space for curative treatment in the wards. The hospital authority has made available some manpower resources to enhance the services in this area. For activities outside the wards, depending on the situation, we will have a look at this during the renovation period. I admit that this is a difficult undertaking, but I hope that we can overcome this in order that there will be better environment for the patients. Ms. Alice Mack. Chairman, I support this renovation. The Kwai Chung District Council did have some discussion, and we do support this because there is no way we cannot support it because of the dilapidated state. I visited the hospital. I mean, there is a big difference between the Princess Margaret and the Kwai Chung Hospital, and I mean, the staircases are bad, the toilets are bad. We're not visiting the wards, we're just visiting the hospital. We met the patients and their family members. I mean, I'm sure that you're aware that handling a case involving fatality, that the facilities in the hospital are so bad, and they're complaining that they don't enjoy any privacy inside the ward. With this $48 million, can you provide better treatment and better services to the patients? Now, we do look forward to redevelopment. I mean, you have my sympathy. This is a difficult project, and I hope that in the run-up to the redevelopment, we're spending these $48 million to provide better services to the patients, to avoid any tragedies. They feel a lack of privacy. They feel a lack of space inside the ward. From what they said, now we can't go in, but from the patients, the beds are so crammed together, and the nurses didn't spot a patient being locked in a room for more than an hour. Now, if you have enough space, all these tragedies could have been avoided. With these $48 million, will the administration or the hospital give us the assurance that the patients will enjoy better services? Under Secretary, thanks very much, Ms. Alice Mack. We do really want to get the funding of $48 million to effect improvement to the two blocks in terms of repair and maintenance, and to provide a more pleasant environment for the patients. Obviously, for clinical services, this $48 million will not be devoted to that. This is merely devoted to repair and renovation. As Dr. Low said a few moments ago, we do have plans to get on with the renovation in phases, to make it more pleasant for the patients to stay in the hospital, and also to minimize the risks. All right, Mr. Albert Chan. Chairman, if I may put two simple questions. This is a price tag of $48 million. I'm not sure why this is borne by the hospital authority. Why do we have to single this out? Is this a special arrangement? Are there any particular justifications for this? I know this place pretty well, although not in great detail. I've got a question, a simple question. Now, with regard to this Kwai Chung Hospital, is this suited to being used as a psychiatric hospital? The environment is really impinging on the psychiatric state of the patients. Now, proper psychiatric hospital should be like a holiday villa with lush green environment, like the Castle Peak Hospital. Now, this Kwai Chung Hospital, with the state it is in, I doubt very much it is suitable for being used as a psychiatric hospital. I think ideally you should redevelop the Kwai Chung Hospital elsewhere. Now, if you treat the mental patients here, the recovery rate could be low, and there can be relapses, and it is likely to cause deterioration in their cases. The environment would have an impact on people. Hong Kong is a city with a high instance of mental illness. This has to do with the living conditions, the absence of the standard working hours, the political repression, the excessive police power, and all the rest of it. The Kwai Chung Hospital, I doubt very much whether it is suited as a mental hospital. I would support the improvement, but I still feel that it is not the right place for the psychiatric hospital. Under Secretary, Chairman, on the first question, now why do we have to come here for the $48 million and not put it under the budget? of the hospital authority. Now, if an amount goes over $31 million, then we cannot really subsume this under the hospital authority budget. We have to come to the finance committee. That's point number one. I'm grateful to Mr. Albert Chan for his views regarding the suitability of Kwai Chung Hospital as a psychiatric hospital. Now, this is precisely the reason why we like to secure members' approval to get on with the renovation of the wards and provide all the necessary services. The Kwai Chung Hospital was commissioned in 1981. It has been providing services to the patients throughout the years. I can certainly invite Dr. Low as to whether it is faring worse than other hospitals. Perhaps Dr. Low can fill us in on the details. Dr. Low? Thank you very much, Mr. Chen. Psychiatric care in Hong Kong has been developing in Hong Kong. We'd like to focus on two areas. The first one is community support. The other one is hospital service. The hospital authority has been advising the administration to invest in support for community care, and that the resources have been going up. The Kwai Chung Hospital was commissioned in 1981, when at that time we put a lot of store by hospitalization. Now, these days, in terms of privacy, in terms of care for the patients, there are certainly some constraints regarding patient care in this kind of environment. So we're going to be redeveloping the Kwai Chung Hospital, and all the concerns highlighted by Mr. Chen would be addressed. I would like to make improvement to the environment of the Kwai Chung Hospital to make it more pleasant, more desirable. Now, we do have all the indicators, and all the indicators are within the range, a number of hospitalizations, so on, a number of days of hospitalizations. They are not particularly high. We are in step with other psychiatric hospitals. Mr. Chen, well, I hope that with more resources available, you should provide more greenery in the hospital. More plants should be provided to upgrade the environment. On the corridor, you may not be able to put some planters there. You can put some paintings there with green trees. If you go to Taiwan, for instance, they do have the artificial relics, even in train stations. I hope that you would provide a better environment for the patients. Mr. Chen Kim-po, Chairman, thank you. During the renovation period, the Kwai Chung Hospital will be in service. I'm wondering whether there will be implications on the patients and also on the people involved. Will there be any reduction in the number of patients? Would there be any triage of the patients and divert some of them to other hospitals? It is also said that the Kwai Chung Hospital facilities are not conducive to the provision of service, modern kind of services. Now, with this redevelopment, what sort of services and facilities will be provided to bring them up to date? Have you also reviewed the number of patients in Kowloon West cluster? Will there be an increase going forward?
Under Secretary, please. Thank you, Mr. Chen, for the question. For the renovation and redevelopment of KCH, we have already assessed the implication, the impact on the patients and their family members. We have already discussed it with all these with the district council. As for number of patients, Dr. Low can tell you more details about it, but we try to minimize impact on them. That's why we carry out the renovation in phases. We do not renovate the 2 blocks in one go. As for your second question, I'll defer to Dr. Low. And thank you for the question. Over the past 3 years, in Kwai Chung Hospital, we handle over 3,000 cases annually. We're talking about inpatient as well as outpatient. And as at the end of March last year, I have to tell you, we have handled over 3,600 cases in 2011 2012. We do not foresee any implications for hospitalized cases. As for the operation, we will maintain the 920 beds. That's why we can maintain our services. For outpatient services, we have over 200,000 outpatients last year. We do not expect any decrease in this regard. And we have to look at the demand for mental health care from the public, and we expect there will be an increase in the demand. But I have to tell you, we do not expect much changes in terms of patients reserved, number of patients reserved. We hope we can maintain the existing services. And after our assessment, we do not have any plans for triage. What about the problem of modernization? You do not meet that requirement at present. And what do you look at after the redevelopment? For psychiatric care, apart from providing support in the community, we also provide daycare services. And space required for daycare services is different from hospitalized cases. At present, we can only make use of the vacant wards to provide daycare services. It is not satisfactory. In the past, the wards were rather closed in and there was only limited space patients could use. For long-term hospitalized patients, they do not get much chance to go outdoor. So in terms of the utilization of space, we hope we can address this in the renovation and redevelopment. With the existing layout, we cannot address all these issues. We have questions also. I heard that the design or the design of beds, the size of beds in public hospitals are subject to certain requirements. That means even if we're talking about a spacious hospital, there is a limit to the space every patient is entitled to. Is it true? Yes, we do have such a requirement. So there is this requirement then. Yes, we have required space for every bed. How large? 6.5 to 7.5. 6.5 to 7.5 square meters. So you're talking about the space in the wards. That means every patient is eligible to 7.5 square meters in a ward. What about the bed space? I'm sure next to the bed there will be cabinets, and all these will cover 7.5 square meters then. After the redevelopment of Prince of Wales Hospital, the space every patient can use is not improved. That means you can really shake hands with the other patient. But in certain other areas, they're rather spacious. In that case, can you allow a patient to have 10, 11 square meters instead of 7.5 square meters? That may make things more comfortable for them. How come you have to set it down to 7.5 square meters? Now that means the space in the ward he is entitled to, but we do not have any requirement of patient space in the corridors. But even if they enjoy lots of space in the corridor, it's not exactly what the patients are asking for. They're looking at the space they get in the ward. How come you have the 7.5 requirement? A member raised the issue of privacy. If a patient gets more space, then of course you can improve on their privacy. This is a planning requirement, in fact. Over the past few years, we already recorded certain improvements. Before that, the space was 5.5 and 6.5 square meters, and over the past few years, you see we have made steady improvement in this regard. Can we make it to 10? Well, there will be implications on public resources. We have discussed with relevant government departments for various projects to see whether we can improve on these. We have set it down to 7.5 and take it forward to 10. It's not exactly impossible, but at present the requirement is 7.5 square meters. Perhaps you can go back and look at the requirement. What I talked about is that we are talking about a large spacious hospital, and in every public hospital we have open air car park. I don't know why you need that. Since you have space, how come you cannot give the patients more space? Now, for this item, may I ask whether members agree to give our support? I think yes. All right. We'll support their funding application. Let's move on to the next item. Does it mean that we have to ask some other government officials to come in? Next item, Elderly Health Assessment Pilot Scheme, EHA Pilot Scheme. Discussion paper and background brief have already been tabled. So, as Under Secretary, would you like to wait for your colleagues to come in? Yes, please. Under Secretary, would you take us through the paper, please? Yes, thank you. Now, next item is about Elderly Health Assessment Pilot Scheme. We hope we can launch the program in the middle of this year. Over the past few years, we have been promoting primary care development. And for this particular program, in fact, you understand that we rolled out other pilot schemes, for example, healthcare voucher schemes for the elderly. It's one of the many pilot schemes. One of the intention for this primary care program is that we hope we can put greater emphasis on this aspect. We hope we can form a closer liaison with family doctors, between the elderly people with the doctors. We would also like to encourage them to make use of the resources in the community and to have better health assessment. For the pilot program, we work in collaboration with NGOs by providing voluntary protocol-based subsidized health assessment. The assessment seeks to identify risk factors and to help promote a healthy lifestyle. Under the pilot scheme, we encourage the NGOs to give health assessments to over 10,000 elders. We have earmarked $12 million for the 2-year pilot scheme. The government will provide NGOs participating in the scheme a subsidy of $1,200 for each elderly person receiving healthcare assessment service, and each participant will have to pay a co-payment of $100. We have Dr. Leung from the Department of Health here today, who will tell you more about the details of the health assessment. The Department of Health will very soon invite proposals from the interested NGOs. We hope the program will be launched in the middle of this year. And I welcome members' comments. But before that, may I ask Dr. Leung to tell you more about the health assessment? Thank you. For this EHA pilot program, it's going to be a subsidized voluntary scheme. There will be a baseline health assessment so that we can identify the risk factors in terms of health for the elderly people, so that we can handle all these risk factors and health problems in a timely and targeted manner. For the scope of baseline health assessment, we based it on the Hong Kong reference frameworks for preventive care for elderly adults in primary care settings. There are 3 parts to the assessment. First, the baseline health assessment. Next, we have follow-up consultations to be followed up by health promotion. For the baseline assessment, there will be health interviews, physical examination, and laboratory investigations. All these are to the ends of reviewing and documenting the level of function and risk profile for the elderly people. After that, there will be 1 or 2 follow-up consultations in which elderly people will be told about the results of the assessment.
And also, to deal with all the health problems during the assessment, if necessary, the senior citizens will be referred to medical practitioners or other allied professionals for follow-up action. We also have an element of health promotion to empower the elderly people to manage their health risks and problems identified through the baseline health assessment. Members may wish to refer to the paper for the details. We attach a great deal of importance to quality assurance. First of all the participating NGOs have to have the clinical experience regarding the elderly care. There should also be a registered medical practitioner who is a fellow of the Hong Kong Academy of Medicine, Family Medicine or Medicine as clinical advisor. We have the information kit made available to the users. When they provide the services, they have to keep record and provide progress reports on a regular basis for monitoring. We hope that next month we will be inviting all these NGOs to make proposals regarding the pilot program for implementation of the 2-year program in mid-year. And we will be conducting a review in terms of feasibility and also the acceptability of the program and the effectiveness. Of course, with the data becoming available, we will then consider how best we can put in place a primary care mode that would be suitable for Hong Kong. Thank you. Well, we have Mr. Lee, Mr. Dr. Kwok, Ms. Alice Mark, and Mr. Fernando Zhou. 4 minutes each, please. Professor Lee, Joseph Lee. Chairman, I support this pilot program, but there are issues that left me scratching my head. I'd like to follow up. Now, the government is applying this principle of money follows the people. I welcome that. Now, those aged 60 or above can join the health assessment clinic, the EHC. Now, you have all these assessment and follow-up consultations and so on. Now, how are they different from what is being done for the EHC? Now, for those aged 70 or above, there will be a subsidy of $1,200, and they will contribute to a co-payment of $100. How do you come up with these elderly patients? Do they not suffer from any chronic diseases? Now, this program is intended to keep them in health, and if there are problems, they will be given treatment. Now, if they're suffering from chronic diseases, you're not achieving this purpose. And this is the second question. Third, this will be outsourced to NGOs. There are so many conditions attached to the program. How many NGOs are qualified to do that? Why don't you increase the number of manpower in the elderly centers? Or is it the case that because of the huge price tag, you're just farming this out to the private sector? Third, those above 70 can join this. Now, you told us that people will have to wait between 14 to 21 months. Now, let's say you can cover the 10,000 people here. How much shorter will people be kept waiting for those aged 60 and above? Undersecretary, thanks very much, Mr. Lee, for your question. Now, this pilot scheme regarding elderly health assessment for the elderly. Now, it is basically similar to the health assessment conducted by the EHCs under the DH. Now, in terms of assessment, we have the baseline health assessment. We will be following the latest reference framework for preventative care. A couple of years ago, when we developed the primary health care, we formulated the reference framework for preventive care. There may be a bit of subtle differences, but basically they are similar in terms of mode of service. Now, for those aged 70, they may be suffering from chronic diseases. Now, one of the reasons why we would like to collaborate with NGOs is that they do have certain network in the community. As Dr. Leung said earlier on, in the community out there, for the NGOs to be qualified, they have to be providing these kind of services all along. So the senior citizens in the community, if they're suffering from chronic illnesses, or if they have joined the Department of Health's program, then they cannot join this pilot program. We'd like to have the electronic platform, the EHR, to register the senior citizens. We don't really want the senior citizens to be part of both schemes. Now, there was a suggestion that we increase the places in the existing services. Now, we are with regard to these primary health care, we like to have collaboration between the public and the private sectors, and we also like to make available more choices to the members of the public. The Bureau has indeed taken on board, into account members' queries. Now, with regard to the EHCs and elderly health centers, they are developing steadily. We don't have any intention or plan to increase the number. Now, we're bearing in mind the aging demographics in Hong Kong, so we would like to provide more choices in the community to the senior citizens. Now, these $100 co-payment, they can meet the payment with the health vouchers that they are given. We'd like to develop the primary healthcare services more. Professor Lee, well, I've gone over the time, I know, but I'm concerned that this $12 million will be down the drains. Now, the fourth question remains unanswered. The other two questions, I think the reply is really ridiculous. So how can we make sure that this is going to be done properly? Right? You will have ample time for the second round. Well, I may not be able to get the reply. I'm just expressing my concerns. Dr. Kwok, Chairman, I am really puzzled why we have this pilot program. This is nothing new. Between 2007 and 2012, from the papers to LegCo, we see that for the EHCs, Sha-Tin Lek Yuen, the waiting time is 4 to 3.5 months for a couple of years, 2 years for Wan Chai, 33 months for Yau Ma Te. I mean, a lot of senior citizens are waiting for the EHCs, and you are creating this pilot program. It will be very hard for us to raise an objection to any pilot of this nature, but our concern is that you just try to make up for the right number. And maybe if people ask for 10,000 places, then they just provide through this manner. There are many singleton elderly people who are on very low pay, and they are queuing up at these elderly health centers. And you're not really fast tracking the services for these people in the queue. Now, with this pilot program, we're not sure how the NGOs are going to be managing this. Is it going to be as easy as the DHS scheme? Now, for the Department of Health, everything is very clear. If they are taken ill, they can just go to these clinics. This is known to the whole community. We're not sure about how the NGOs are running the program. No respect to the NGOs, but I mean, I'm concerned that the $12 million will be down the drain. So you're just making up the right number. If they ask for 10,000, you just create these 10,000 places. You should really provide the relevant services properly. Now, how can the NGOs identify the right people? I don't think this is a secure way of doing it, unless you were to say that the EHCs are really not running properly. I mean, if this is the case, you should really get rid of them. Now, the Department of Health has already had these structures. And this is a pilot program. There are tens of thousands of senior citizens in our midst. You don't really need to have a pilot program. They do want to have checkups on a regular basis. If you have elderly members in your family, you would understand this. Those coming to the EHCs would not be coming for fun. They don't really have any resources. Why do you have to create this kind of pilot program? Why do you have to create this kind of mess? Undersecretary, thanks very much, Dr. Kwok, for his views and the queries. Now, when we develop the primary health care, we'd like to highlight the importance of prevention. And for the secondary and tertiary levels, like hospitalization and rehabilitation, we can reduce the utilization of these two levels. And we are providing a bigger range of choices. Now, the reason why we have to engage the NGOs, now some members may not have any faith in the NGOs. Now, we would like to do something positive for the senior citizens, not just by the government, but also the NGOs as well. Now, the NGOs do have to fulfill certain criteria. It's not the case that all NGOs would be eligible. We do have the monitoring mechanism. They have to produce reports on a regular basis. Perhaps Dr. Leung can fill members on the details. Dr. Leung? Well, whether there are any NGOs that fulfill the criteria, as far as we know, there are more than 10 NGOs that currently providing medical care or health assessments for the senior citizens. We're talking about a dozen or so such NGOs. So we will not run out of these candidates. There was a question about how we can identify the senior citizens. Now, as you all know, there are about 10,000 or so who are queuing up for the elderly health centers. And it would take about 12 months for them to be admitted. And if a center has a particular long queue, we refer them to the centers with a shorter queue. And we also tell them that there are NGOs in the community that are running similar health assessment service, and they are welcome to join them. With this pilot program, we can refer some of the waiting senior citizens to this pilot. I'll wait for my next turn then.
Miss Alice Mack. Now, this is a pilot scheme, but what will happen after it? Has the administration formed any direction forward for this? Well, there's no way we can object to the program. But with our support, you will spend the money, and the scheme will carry on for 2 years. What will happen after that then? In terms of primary care and elderly health assessment, what is the direction forward? It seems to me that you do not have any plans after this. Now, people will have to pay $100 to enjoy the services. You may say they can use the healthcare vouchers. But many elderly people would like to save the vouchers for medical consultation. That's why they would rather queue up for a longer time. What do you think that they would like to get the assessment? They may not think there is an urgency to undergo any assessment, and they will rather save up the vouchers for medical consultations. Next point, the threshold is 70 years old. What about those aged 65? You have to let these people know that if they have any health problems, so they can get early treatment. How come they have to wait till 70 to enjoy the services? Well, 5 years down the road, they will suffer from worse health. I don't know. This is not exactly a scientific thought. But still, is it better to provide the scheme to people when they are younger, say 65? Thank you. As said, this is a pilot program, and we hope after we have launched the scheme, we will gain some experience. We will certainly have reviews. We have yardstick for the reviews as well. In most cases, we have to look at the feedbacks after a program is rolled out. For example, the feedbacks of stakeholders and for the competence of the service providers. And in the long run, we also have to look at the financial commitment of the administration. One of the main ideas for primary care is we look at the reference framework, and with that, we will provide more support to the elderly people in the community in terms of health assessment. So in the long run, we would like to provide primary care services in the community. And you said maybe the elderly people would rather save up the vouchers, and they do not recognize the importance of identifying the problems at an early stage. When we liaise with the NGOs, we ask the NGOs to provide publicity and promotion activities so that elderly people will understand the importance of early identification of health problems, so that they will not simply look at the money issue. And another question about setting the age eligibility at 70, not 65. Now, this is a pilot program, and we look at and it is a risk-based program. We cover those aged 70, but not those aged 65. Is because the threshold for EHC services is 65. That's why we set down the threshold for this program at 70. So when you are 65, you are regarded as a senior citizen by the EHC, but not by the pilot program. So you are applying double standards here. And this is a risk-based program. Does it mean that the people aged 65 do not face high risk? This is a pilot scheme, and we will assess the effectiveness once it's launched. After it's launched. Dr. Fernando Chang, this is a puzzling program. I do not see why it is a pilot program. Soon after the handover, we established the EHC, and this program is doing exactly what the EHC are doing. I do see the difference. More than 10 years after the EHC, we have this program. Have you done any assessment on the EHC? Are they effective in rolling out primary care in the community? You do not have that, and you do not have any ideas about that. And out of the blue, you have the pilot program, which will cost you $1,200 for each elderly people, or $1,300, including the co-payment. Is it the case that the government is now dragging its feet? Will you outsource the EHC to the NGOs after 2 years, this 2-year pilot program? What's the unit cost for the EHC at present? Thank you, Dr. Chang, both for the question and the comments. Health assessment for elderly people is now currently provided at EHC. We would like to work together with the NGOs as well in the community, because they have already got a network in the community. And that's why we hope they can include primary care services as well. So in terms of pilot, it means you focus on the service providers, but not the users. We have 980,000 people who are 65 years old, and with this scheme, you're going to serve only 10,000 people. Why don't you tell me how much are you paying for each elderly person who are receiving services at the EHC? So just give me the figure. Right, the unit cost. Before I answer your question, I can tell you we do not have any plans to cut back on the services provided by DH. Maybe I did not express myself clearly. Our focus is not just on the service providers. We also focus on the services to be provided. We came up with reference framework for primary health care services. We have a particular framework for elderly people services. We know the diseases elderly people are most prone to, and these are addressed in the pilot scheme. As for the unit cost, perhaps Dr. Leung can tell you about it. Yes, the unit cost, 2011-12, for the expenses for healthcare services, healthcare assessment for each elderly people, $1,990. So $1,090, but when you work with the NGO, 1,300 or 1,200, that means there is a rise in cost. Or are there some other elements in the cost which are not covered? That means the services provided by DH is cheaper than those by NGOs. Well, this is really hard to believe. I think it's because for many members with EHC, they tend to renew their membership and they are of better health. That's why they do not require so much services. I think this is one of the major reasons to explain that. Are you making a fair comparison? No. No, it's not. You cannot compare the unit costs of the two programs. Well, they're comparable, but they're not exactly the same. Next, Mr. Albert Ho. When the Undersecretary gave her answer, she said, at present, the services provided by EHC and the pilot program, they are more or less the same. And they're simply offering more choices to the elderly people. Now, let's say I'm queuing up at the EHC, say for example for 15 months. And I have another choice if I'm over 70. But you're telling me the services are more or less the same. Why do I have to switch to another program? If you're saying the other program provides more, it's different. So you have to provide more details. Sometimes I don't understand why we have such programs. Now, for RCHEs, elderly homes, people have to wait for a long time. And the government came up with this idea of aging in place. Now, in this regard, they are different. Now, let's leave the performance and effectiveness aside. But coming back to this, the services are more or less the same. Does it mean that people can quit queuing up at the EHC? When I said they provide more or less the same, they are more or less the same, I mean the mode of operation is more or less the same. The health assessment under the pilot scheme, provide assessments based on the latest reference framework. So this is one of the differences. And another point is about the follow-up consultation. There will be 2 follow-up consultations after the assessment. The first one will be carried out within 2 months after the assessment. The doctor will have to explain the reports to the participant, and if necessary, the patient will be referred to other services. So there is a pledge, service pledge, to come up with a first consultation after 2 months of the assessment. There will be a second follow-up consultation 4 months after the first consultation, if necessary. And that is not necessarily to be conducted by a medical practitioner. Other professionals from the NGOs can also follow up on the participant. Dr. Leung, anything to supplement? No? Well, in that case, it seems to me this program is better because it provides more. Otherwise, you have to tell people about it. Otherwise, how can you persuade people to switch to this? Now, will it be the case that the NGO can choose the patients? If that's the case, what are their criteria? For those with chronic diseases and with high risk, are they going to queue up for a shorter queue? I think the most logical way to go about it is to put in more resources to improve on the existing ones. But still, you have to tell people about the details. That means the pilot program is better. No, this is new, and it's a pilot program, and we're working with the NGO. They have their own network, so maybe the queuing time will be shorter. Dr. Leung, do you have anything to supplement? Dr. Leung.
Chairman, in a community, if there is an NGO that has taken on, let's say, a quota of 500 or so, then these places will be made available. If the senior citizens are waiting in one queue and they switch over to this NGO, that there would be a faster queue, and there will be fast tracking. So it would be for the NGOs to pick someone to jump the queue, and they make available better services, although they cost more or less the same. Is it for the NGOs to select the users? Well, I suppose it would be a first come first served arrangement. Well, if you can run a marathon race at the age of 70, then I would deny you the service. I would make it available to someone who is wheelchair bound. So how do you select the people? I think it would be first come first served. Well, I suppose the NGOs would have the discretion, wouldn't they, to select the right people. Well, who's going to take the floor? Let me have a go, Chairman. Through today's meeting, I would like to hear what members have to say. We do have some preliminary liaison with the NGOs, as Dr. Leung alluded to, but we still have to look at their proposals and engage them in further discussions. Mr. Ho asked whether it is first come first served or whether the NGOs would pick and choose. We will have to liaise with the NGOs in order to come up with the best possible way to serve the members of the public. Mr. Wong Ting Kwong. Chairman, thank you. Whether this is taken forward or not, the administration will be in the firing line anyway. As far as I am concerned, we better get on with this pilot program. Now we have the EHCs in the 18 districts, and the waiting time can be ranging between 14 to 20 odd months, or 1 or 2 years. Now this pilot scheme will be reducing the demand, or will be fast-tracking the availability of services of health assessment for the senior citizens. For this to be a success, I think the administration has to step up the supervision of this pilot program. I mean, you should not be just going through the motion, like some fellow councillors said. You shouldn't be just come up with certain statistics. Also, I heard from your reply the follow-up services. Now, if certain senior citizens are found to be suffering from certain ill health, there would be 2 follow-up consultations. I don't think that would be quite sufficient, because they have to be referred to the medical institutions for the problems to be addressed. If I may put a question here, now you mentioned the eligible NGOs. There are a dozen or so available all over Hong Kong. Have you got any eligibility criteria for the NGOs in place? Will you consider, subject to this pilot program becoming a success, extending this to people at a lower age, like 65 instead of just 70? Under Secretary. Thank you, Chairman. Thanks very much, Mr. Wong. In answer to your question, we would like to gain some experience. We also would like to gauge the acceptability on the part of the general public and the users. We will be looking at this at a later stage. We will not be stuck with just 70 years old. Now, the eligibility criteria for the NGOs, I can defer to Dr. Leung in just a moment. Let me add a little bit to the point you made about the follow-up consultations. Now, 2 follow-up consultations, are they enough? We are offering $1,200 to the NGOs, and they have to conduct these 2 follow-up consultations, and these NGOs are providers of elderly services, and they can make referrals, and the extra costs can be borne or can be met by the voucher scheme. I'm just saying that for these 2 consultations, they are included in the deal for the NGOs. Other than the follow-up consultations, we also have health promotion. We will be empowering the elderly people to learn about healthy living. In terms of monitoring, the NGOs have to submit financial reports on a regular basis, and there is also a requirement for a medical practitioner to be stationed there. Perhaps Dr. Leung can fill you in on more details regarding the eligibility criteria. Dr. Leung, as we said earlier on, there will be a selection panel that will be sitting in judgment of the eligibility of the NGOs and see whether they are currently providing any health assessments or clinical services to the elderly people. The selection panel will have regard to the track record of the NGOs, and also whether they will measure up to the requirements under the pilot program, like the equipment and facilities of the clinics, the laboratory investigation level, the qualification of the medical personnel, and so on. Mr. Kwok Wai-Keung. Chairman, thank you. I'm sure we all recognize the fact that senior citizens are the treasure of our community. We'd like to show more concerns. We'd like to take care of them. And we'd like to formulate services for them. And this is conditional upon the proper utilization of the resources. Now, the $12 million is far too low as far as I'm concerned. The Financial Secretary mentioned the massive surplus. Now, we have 700,000, 70 euros and above. Now, we would like to find out about the effectiveness of the pilot program, but in the long run, we'd like to cover every single senior citizen instead of just 10,000. Now, the percentage is really too minuscule in the overall scheme of things. I meant to make a point. I think we should cover the invisible elders, the isolated elders, and those who do not enjoy these services. That you said that there will be a subsidy of more than $1,000 per elderly, and it will be difficult for you to locate the isolated senior citizens. Of course, where possible, we can increase the amount to such an extent that the NGOs would also be in a position to identify these senior citizens who are socially isolated. Now, these socially isolated elderly people don't really enjoy a community network, and they don't really venture out into the community. If they can be identified, then it would be standing them in good stead. So if we can increase the amount, so much the better. Otherwise, I think that the senior citizens should be beyond the senior citizens who are being served at the present moment. Now, there are so many senior citizens who are always part of the events, but there are some who are more reclusive, who are more socially isolated. I don't have any problem with the pilot program, but thereafter we should consider how best we can take this forward. As the next step, we shouldn't wait until the findings becoming available. You should have some ideas how we should take this forward. I mean, if you leave it till the findings become available, then it will be too late. So prevention is always better than cure. If they can be given an opportunity to identify the illnesses earlier, it would be better for them. Under Secretary, thanks very much, Mr. Kwok. Grateful to your point about the senior citizens who are socially isolated. Now, for those who have been involved with community work would understand that it is always the same group of senior citizens who are using the services, and there's so many who are socially isolated. And that's precisely the reason why we like to collaborate with the NGOs, because they do have their own social network, and they have their own targets of service, and they can reach out to the social isolated elders and enhance their prevention or preventative consciousness. And in our dealings with the NGOs, we certainly will hammer home this point. You mentioned the assessment. In fact, the DH does have the plan to conduct assessment. And first of all, in this pilot program, we adopt the reference framework for preventative care for older adults in primary care settings. And we have to ascertain the number, and there may be some senior citizens who previously were not diagnosed as having any health problems, and we should also promote a community-based care model, and we would like to enhance the primary physicians and provide sustained personal care services, not just medical consultation, but also health care, counseling, and health promotion. So all these will be subject to review in mapping out the next step. Mr. Lee, Mr. Kwok, Ms. Mack, and Mr. Zhang for the second round. Anybody else for the second round? Mr. Kwok Wai Kang? All right, this will take about 15 minutes. 3 minutes each, please. Right, we have to maximize the time available, please. Professor Lee, Chairman, the more I listen, the more frightened I feel. In paragraph 5, there is mention of the Hong Kong reference framework, which is mentioned by the Secretary so many times. That if the NGOs do not adopt this reference framework, I mean, why do I have to adopt this for the NGOs if this is such a good thing? And I'm not suggesting that we should apply a double standard. Now, for those above 70, how to identify them? Now, we agree with this pilot program, of course. Those in the queue do not have to go to the government service. They can come to the NGOs. But you fail to tell me whether these people are suffering from any chronic diseases. Is it the case that they can go to these NGOs for sustained health assessment and early intervention? And what is the role of the NGOs? I mean, that's something I find it bewildering. Second, now for the NGOs, many of them are currently providing these services. If they manage to get a job, then they will have a due track of service. Some will be charging $100 or more, but for the other track, they have to follow the reference framework, and in order to get the $1,200 from the government. Now, you said you have a dozen or so such NGOs. All of these are very complicated, and I'm concerned that all these will become really a bad thing. Now, for these 70-year-olds, if they move over to the NGOs, how much time will be shortened for their wait? Now, of course, we're going to earmark the funding, $12 million. I mean, it is not a lot of money, but will you come back and make a report to us, let's say, in 6 months' time? Well, the $12 million, I mean, it is not a lot of money. Undersecretary, thanks very much, Professor Lee, for your question. We're here to listen to members' views. Now, you are suggesting that the DH will also adopt the reference frameworks. Now, when we liaise with the NGOs, and if they have the NCDs, and they don't have to check because they're aware of them. In the process of assessment, we would like to identify the risks at an early stage, let's say if they are visiting the hospital authority for the illnesses, then it will not be appropriate. As to how the DH can monitor the NGOs, perhaps Dr. Leung can supplement with further information.
Please be brief. Let me talk about the difference between services provided by the EHC and the pilot program. For the EHC, they started over 10 years ago. For the reference framework, it only came into place recently. That's why the pilot scheme will follow the reference framework, whereas for the EHC, it is not using it at present. And since we have already announced the framework, we will review the services provided by the EHC. Now, there will be 2 follow-up consultations under the program. What if the patient has to receive therapy or occupational therapy? We know for the NGOs, the charges are different from the services provided by the public sector. For therapeutic treatment, dozens of dollars are charged at public sector, but $500 with the NGO. If it continues under the program, it is outrageous. Well, for some programs, they are self-financing, but you are driving the patients to a dead end. If they join the NGO programs, they cannot be directed to the public hospitals directly. For therapeutic treatment and medication, if they are with the public sector, they will be referred to the appropriate treatment immediately. But under the pilot program, things are quite unclear. So how can you set our mind at ease? Is it the case that you're not going to enhance services at the EHC? You haven't answered my question. I asked if the EHC is not a success. If it's a success and people are making good use of it, how come you are not enhancing the services there? Say, for example, improve the manpower and other areas. Or are you going to do nothing? Third question. Now, people have to wait as long as 14 months at the EHC. With this program, is it the case that the waiting time will be shortened? Thank you, Mr. Kwok. About the referral. For the 2 follow-up consultations, referrals are covered. If illnesses are identified, diagnosed, and there should be follow-up consultations, but the patient cannot afford services with the NGO, then he can be transferred. But we have to make assessment. We have to see whether the HA can accommodate that. But of course, you have to wait longer with the HA. You wait shorter time if you pay higher price at the NGO. We appreciate that. But the senior citizens can use the healthcare vouchers under the pilot program. If the NGO is also one of the service providers under the voucher scheme, senior citizens can use the voucher scheme. And at present, we do not have any plans to cut down on the services provided by EHC. Lawmakers have many questions as to why we're not enhancing services at EHC. It's because we want to provide more options in terms of services, and there are NGOs already providing similar services in the community, and they are really reputable. We would like to encourage them to do more to provide preventive care for the elderly people. This is the strategy, one of the strategies under the primary care services development, and is also in line with the public-private partnership approach. It's not the case that because the government doesn't take up the service provision, we ask the NGOs to do so. We have to extend the meeting. Next, Ms. Alice Mack. The FTU supports the program, but we hope you have a clear direction ahead. You may say you will have assessment, but please don't put it to an end after the assessment. In that case, the $12 million will really go down the drains. I hope the program will really benefit elderly people. And, well, there are many programs that are cancelled after they have been rolled out for some time. In Hong Kong, we have had experiences of public-private partnership. Now, how can you adopt this approach so people will turn to private sector for healthcare services? You have to understand many members of the public rely on the public sector for those services. Even with a choice, they would rather go to the public sector instead of the private sector. So how can you encourage them to go to the private sector and shorten the queue at the public sector? You say they can make payment with the vouchers in paying the co-payment. How can you encourage the elderly people to do that? You have to tell them what do they stand to benefit under the program. I think you have to do more in terms of publicity. Next question, how come you do not lower the eligibility age to 65? When you are 65, you can use services at the EHC. What you are proposing means people between 65 and 70 will still be using services at EHC. So how come you do not lower the threshold to 65 so that this group will move to the private sector for the services? I hope the pilot scheme can really set down an idea of healthcare services to be provided in the community. Thank you, Ms. Mack, for the many comments you have expressed. They are useful to us in terms of development and our way forward. For publicity, yes, we have to do that. We hope the senior citizens will attach more importance to preventive care. I'm sure when we liaise with the NGOs, we will make it a point that they should do that. For this program, we're asking for $12 million funding for people aged 70 or above. We note your comment on lowering the threshold to 65. We'll see whether we can lower the threshold to that age. Next, Mr. Fernando Chang. Well, it's hard for us to raise objection to the proposal because you're proposing to give healthcare assessment to elderly people. But the proposal is really too rough. EHC has been providing similar services for over 15 years. Under this pilot program, what sort of effect is it going to make in terms of primary care services? What sort of effectiveness is it going to, are we going to see so that elderly people do not have to go to public hospitals and specialists at an early age? And which group of senior citizens will benefit most from the health assessment? And can you really do a proper job in terms of the follow-up consultations? If there is a difference in terms of service provided by DH and NGOs, what sort of impact are we looking at? We don't have any idea. We have 680,000 people aged 70 above, and you're only providing services to 10,000 of such people per year. That means you're looking at those with urgent needs. I do not see anything related to logical thinking and public health care services planning. I will not object to the proposal. It's better even for you to apply for 120 million to serve 10,000 elderly people. But you seem not to have gained any experience to enhance such a pilot program. Do you get my point? What I'm telling you is really the basics. This paper is really too rough. Is it the case that you conducted lots of surveys, but they are not here on the paper? Dr. Cheng, I haven't really got a chance to answer your previous questions. For the EHC, we have conducted assessments on their services. Perhaps Dr. Leung can tell you more about it. And if we cannot supply it here, we can supply it afterwards. We do have assessment for EHC. You mentioned certain indicators, which I find important as well. Dr. Leung, some details, please. We conducted surveys from 01 to 03. Over 20,000 people registered with EHC. After they have received services, it was recorded that in terms of smoking impact, weight management, and falling, we have recorded improvement. What sort of elderly people are we talking about? Cost effectiveness is important, and you only propose to serve 10,000 people. You have 18 EHCs serving not as many as 40,000 people. 80,000 people is the total number, but you're serving only, say, 40,000. I hope you can supply us with more information, especially on serving elderly people. What group you're serving?
Mr. Rahul? Well, I think we support the idea of health promotion, better primary health care. Second, because of the aging population, we should do more for them. For the chronically ill, we should do more for them. We're supportive of that. For the EHCs, elderly health centers, so we support the improvement there. Now we are presented with this $12 million pilot program for 2 years, serving 10,000 senior citizens. Now there are many who are desperate for these kind of services. Undersecretary, you're from the healthcare sector. You must be aware that many people are not equipped to look after themselves. They're suffering from all manner of illnesses, and you shouldn't wait until they're 70 before you look after them. Now we mentioned 65. It would be far better to start this at the age of 60. Of course, there are resource constraints, but if you start with 70 years old, with $12 million for a pilot of 2 years, I find it wholly unacceptable. We have billions and billions of dollars in reserves, and I'm so disappointed. As I said, it would be difficult for us to object to this. Now, let's say if someone has been diagnosed as having high blood pressure or high cholesterol level and so on, they have to take a medication. Well, I've been on this high blood pressure medication or cholesterol and blood thinning medicine and so on. They don't come cheap. If I may put a question here now for this pilot program, how are you going to look after them in terms of medication? This is the crux of the matter. Medication doesn't come cheap. For the grassroots people, it would be pretty unaffordable to them. So how are you going to follow up on the prescription? Undersecretary, thanks very much, Mr. Ho. Now, for primary health care, we like to enhance the prevention. Maybe we would like to stop the deterioration to such an extent that people will have to rely on medication. And we like to prevent the occurrence of illnesses. Some people may be diagnosed as suffering from certain illnesses. As you mentioned, they need medication. Now, these are $12 million. Is more like focused on prevention. If they are suffering from certain illnesses and they need treatment, then it would be for the hospital authority to follow up, or it would be for the NGOs to follow up with the medical care. Mr. Ho, if they're suffering from certain illnesses, do you know how long people will be kept waiting for the specialist care? A year? More than a year? I wonder how many people can make it through the period. So at the end of the day, the $12 million would not, in my opinion, achieve anything at all. Undersecretary, well, that much we understand. In the community, as I said earlier on, this program is part of the primary health care development. We appreciate that for senior citizens, other than the EHCs provided by the DH and this pilot program, there are also private services that are available in the community. There are services that are being made available by the NGOs in terms of assessment. So in the context of this pilot program, we would like to find out how the different modes of service can be further developed. Mr. Ho, now this new administration is so good at studying, and they are learning the rope all the way through. Mr. Kwok Wai Kang. Chairman, thank you. I'd like to stress one point, the 10,000 people that you cover. it is too small a catchment scope, so people will be really resentful of that. Now, with the $100 payment, you're trying to screen out certain people. This 10,000 quota is really too small. I think it would be a good idea to cover all the needy elders. Now you are stumping up $12 million. So why do you have to be concerned about the $100? Now some members said that they are bewildered about the provision of this pilot program. I think we should look upon this as a starting point, because we haven't done quite well enough. But I think you should try more vigorously. Now we are so concerned about this pilot program, and I think it would be a good idea for the administration to come back for a midterm review. That would assuage our concerns. And NGOs can certainly give their feedback about the difficulties that they encounter in the process. I think we ought to have some discussions, some liaison between various parties. Under Secretary, thanks very much, Mr. Kwok, for your views. The NGOs will report to us on a regular basis, and they have to submit regular reports. They'll be monitored by the DH. You are suggesting that a midterm review be made available. Now that should not present any problem at all. As we go along, we will build up the experience, and we can certainly gauge the response and so on. We can certainly come back with an update, or you said we have already heard. Well, can you make it free? Short reply. Well, Chairman, now the administration will stump up $12 million, and there will be a co-payment of $100. The cost would be coming to $13 million. I think we have to keep it that way in this pilot, and we can talk about this in our review. Mr. Chen Hanpan. Chairman, thank you. This pilot program is intended to help the senior citizens and help them undergo certain assessment. There is no way we can object to that. We all understand how bad the queues are at the elderly health centers, and this is coming in for a lot of criticism. This quota of 10,000 represent about 1/3 of the EHC's services, and queue will be shortened. I am concerned how you will distribute the quota. Some may be waiting for the EHC. Because of this fast tracking, they will be gravitating towards this side, and they have already paid the annual fee of $110. What's going to happen to the money they have paid? And this pilot program will be a fast tracking. Will it be unfair to those who have been on the waiting list for so long? How can you make sure that there will not be any duplication in the screening of the elders? Under Secretary, thank you very much for the comments. There are some members who raised concerns about the screening and also the quota of 10,000. We'll be liaising with the NGOs in our dealings with them. We hope that they will adopt a fair mechanism to identify the elderly population who need the service. The members may feel that the 10,000 would be on the low side. Now we'd like to get on with this pilot program first and see how this can be beefed up going forward. Now with the aging demographics in Hong Kong, the services for the elderly, preventative, curative. There has been an upsurge in demand for various kinds of services. And this is something that we have decided on as a pilot. And if we will have a look at the response, we will conduct an assessment, and then this can be enhanced going forward. Mr. Chen, what about the double payment? They've already paid the money at the EHC. Undersecretary, now if they have become a member at the EHCs, they cannot come over here because they're committed to that kind of service with the payment of the fee. Now when they're queuing, they don't have to pay anything at all. It's only when they're admitted that they would be paying the fee. Now, if they have already paid up, then they will not be eligible. Let me make some little comment. Now you have the blood occult screening, the fecal occult blood testing, and you will you will cover 10 years. If someone is at the age of 70, they're not all that enthusiastic. It would be not a good idea to check them at this age. Like also renal disease. I mean, at 70, they will not be enjoying any renal or kidney transplant. Why bother checking them in this regard? And now you have $40 billion for the hospital authority and less than $4 billion for the DH. With such a small amount of allocation, I think that explains why you are only earmarking these $12 million. I think we'll have to bring the meeting to a close because of the time constraint. Thank you all very much for coming. Just a reminder that there will be a special meeting on the 25th on the mental health policy and the services. Meeting adjourned. Thank you all very much.